Thank you all for participating in this webinar about patient-centered medical homes being presented by the National Healthcare for the Homeless Council. We are grateful for the support of the Health Resources and Services Administration in presenting this timely and important material. The patient-centered medical home is a term that is being widely used by federal and state government, insurers, national healthcare quality organizations, and healthcare providers. Everyone is asking, will this model be used for required accreditation or funding and reimbursement decisions? The National Council for Quality Assurance, or NCQA, has developed the most frequently used and frequently discussed accreditation model for medical homes. Will this become the gold standard for health centers? And what does all of this mean for healthcare for the homeless programs? My name is Heidi Nelson, and I serve as the CEO of Duffy Health Center, providing healthcare for the homeless services on Cape Cod, and a member of the National Council's Health Homes Work Group. We started the group to provide mutual support to HCH programs that were attempting to or were interested in achieving medical home status. Today's presentation features Joslyn Strupp Allen. Joslyn is the Director of Government Grants and Special Projects at Boston Healthcare for the Homeless program. Joslyn has a master's in social work management and community practice and 12 years experience working with homeless populations. She has led major program evaluations and has been co-author and editor on several publications. At Boston HCH, she takes the lead on administering federal and state grants and manages special projects such as improving internal systems, conducting needs assessments for expansion, and analyzing data for strategy development. In the fall of 2010, Joslyn accepted the role of patient-centered medical home project leader. She is leading Boston HCH's effort to meet Level 3 accreditation, including guiding the team toward changes needed to meet standards, creating the documentation needed for the application, managing project timelines, and conducting a gap analysis. Joslyn's 7 years experience with healthcare for the homeless and newfound experience with the patient-centered medical home model make her a perfect choice to be our speaker today. So I now turn the virtual podium over to Joslyn. Welcome.
Thanks, Heidi. As Heidi said, I'll be doing a brief introduction into patient-centered medical home and how it may intersect with homeless health care. Our agenda today is in 3 parts. First, a review of the patient-centered medical home concept. Second, the reasoning behind this particular HCH's plans to prioritize seeking PCMH recognition now. And finally, a short discussion of some of the early challenges and foreseeable hurdles to recognition for HCH programs. So what is PCMH and why should we care about it? Let's start with the what, and hopefully the why will become more clear. I find that a good way to get my head around complicated policies and initiatives is to start with trying to understand what that initiative is trying to fix, what's broken here. In that vein, I'd like to start the discussion of patient-centered medical home by reviewing what it is trying to fix, today's healthcare system in the United States. You're hard-pressed to open a newspaper, turn on the radio, surf the web, or scan the TV these days without hearing about the dire state of the healthcare system and its rising costs. As this graph painfully illustrates, healthcare spending continues to climb. According to the Centers for Medicare and Medicaid Services, the National Health Expenditure account, which measures annual U.S. expenditures for healthcare goods and services, reached $2.5 trillion in 2009, which translates to more than $8,000 per person, or 17.6% of the nation's gross domestic product. That's up from a mere 5% in 1960. So healthcare costs are outpacing the economy. How does the United States compare with its peers throughout the world? Unfortunately, not so well. You'll see that the U.S. has the dubious distinction of leading the world in this measure. And remember, this is not absolute spending, so it isn't a matter of having more people or being a wealthy country. This is percent of each country's GDP, which means that a greater proportion of the U.S.'s expenditures are on health than any other country's. Surely then we're getting something great for our money and leading the way in outcomes, right? Sadly, no. As all of us in healthcare know, healthcare outcomes don't tend to justify these rising costs. Using life expectancy as a proxy for health outcomes, and in fact as the ultimate health outcome, you can see that the U.S. ranks 49th in the world in life expectancy at birth. So we're spending more and getting less than other countries. And some of us may be thinking of retiring in Macau. So why does the U.S. system appear to fail on measures of healthcare quality? Let's talk about just a few of the prevailing reasons. I think first and foremost is fragmentation. The prevailing model of healthcare delivery is decentralized and convoluted. It's often a complicated web of processes and handoffs that confound patients and frustrate healthcare providers. Healthcare organizations, community health centers, private practices, hospitals often operate as silos, providing care without the benefit of complete information about the patient's condition, medical history, services provided in other settings, or medications prescribed by other clinicians. This model of care is sporadic, scattered, and often redundant. It's also costly and often ineffective. Inequality. Particularly for those whom our programs serve, the healthcare system is often rife with inequality. Patients without money or insurance often find the full spectrum of care to be unobtainable except in emergencies. We see all of the time homeless patients delaying or being denied care because it is too expensive or uncovered, only to need more costly emergency services later. There's also an increase in chronic illness. Studies show that the needs of the American public have been shifting from predominantly acute episodic care to care for chronic conditions. According to a study funded by the Robert Wood Johnson Foundation, chronic conditions are now the leading cause of illness, disability, and death. They affect almost half of the United States population and account for the majority of healthcare expenditures. Though needs are shifting, the patterns of both patients and healthcare practices haven't caught up. Most healthcare activity is still focused on the acute and episodic at the expense of preventive and chronic care management. Again, this national trend is even more prominent and relevant for healthcare for the homeless programs. Among homeless people, we all know that preventive care often yields to the immediacy of life in shelters and on the streets. And illnesses go untreated and often escalate from minor symptoms and easily cured problems into major illnesses and healthcare emergencies. This challenge is at the core of why our programs exist. There's also a notable shift away from primary care, particularly among new doctors entering the field of medicine. There are numerous reasons that have been offered for why this trend is happening, including the fact that there is a perceived expectation that primary care practitioners have to be experts in everything versus having one specialty, that reimbursement and remuneration are both lower for primary care rather than specialty care, that the reimbursement structure is based on quantity and not quality, and that practitioners resist a culture of defensive medicine or fear of litigation in which they feel they must order numerous tests in order to cover themselves rather than trusting their judgment and ordering only what they feel is necessary. And finally, there's growing complexity of science and technology. Rapid advances in both these fields make the healthcare system increasingly complex. Unfortunately, the system, and those of us participating in it, frequently fall short in our ability to translate knowledge into practice and to apply new technology safely and appropriately. These explanations give us a glimpse of what is wrong with the healthcare system today. And so, in comes patient-centered medical home, bringing with it a new focus on primary care. Despite the shifts away from and fears of primary care, it seems that primary care may be the answer. Good primary care is shown to reduce costs and improve quality. Instead of paying for expensive treatment or complications of chronic disease, primary care works to manage disease in the first place. Primary care can also help patients navigate a fragmented healthcare system. patient-centered medical home is a healthcare setting that facilitates partnerships between individual patients and their personal primary care team. Care is facilitated by health information exchange and other means to assure that patients get the indicated care when and where they need and want it in a culturally and linguistically appropriate manner. I mean, who can argue with that? This is a statement that fits directly in with all of our missions. The American College of Physicians, the American Academy of Family Physicians, the American Academy of Pediatrics, and the American Osteopathic Association developed these joint principles or key tenets of patient-centered medical homes. Though the focus was originally on physicians, there has since been a notable shift away from physician-centric language with a greater focus on multidisciplinary teams. The tenets include a focus on a personal physician or primary care provider. This principle states that each patient should have an ongoing relationship with a particular primary care provider or team, trained to provide first contact, continuous, and comprehensive care. Second is team-based care, which states that the primary care provider is part of a team of individuals who collectively take responsibility for the ongoing care of patients. There's also a whole person orientation. The care team is responsible for providing all of the patient's healthcare needs or taking responsibility for appropriately arranging care with other qualified professionals. This includes care for all stages of life: acute care, chronic care, preventive services, and end-of-life care. Care is coordinated and integrated across all elements of a complex healthcare system, including subspecialty care, hospitals, and nursing homes, and the patient's community. Care coordination is facilitated by registries, information technology, health information exchange, and other means to assure that patients get the indicated care when and where they need and want it. Quality and safety are hallmarks of medical home model. This means that evidence-based medicine and clinical decision support tools guide decision-making, that the care teams accept accountability for continuous quality improvement through voluntary engagement in primary measurement and improvement, that patients actively participate in decision-making and feedback is sought to ensure patients' expectations are being met, and that information technology is utilized appropriately to support optimal patient care, performance measurement, patient education, and enhanced communication. There's a focus on enhanced access. Access to care is available through systems such as open scheduling, expanded hours, and new options for communication between patients and the care team. An important component of this tenet is continuity. In other words, it isn't just access, it's access to your care team. I'll talk more later about how this tenet challenges our particular model. And finally, payment reform. There's an expectation that the system should be structured to appropriately recognize the added value provided to patients who have a patient-centered medical home. The hope is that our payers will begin to reframe the payment structure to reflect the value of physician and non-physician staff, to pay for services associated with care coordination, to support the provision of enhanced communication and access, to recognize case mix differences in the patient population being treated within the practice, to allow practices to share in savings from reduced hospitalizations associated with good care management, and to allow for additional payments for achieving measurable and continuous quality improvements. The National Committee for Quality Assurance, or NCQA's, Patient-Centered Medical Home is an innovative program for improving primary care. Through this program, NCQA built on the joint principles to set standards and guidelines that help practices achieve a patient-centered medical home model. It includes a focus on working in teams, which covers the first two principles we discussed before of having a personal primary care provider and a team-based care so that there's care continuity and coordination. It also focuses on organizing care around patients, which addresses the third principle of the whole person orientation, with a particular focus on involving patients in care decision-making and providing preventive services and clinical care when and how patients need them. Finally, there's a focus on coordinating and tracking care, which we've talked about already in addressing those fourth and fifth principles, encouraging practices to maximize the use of health information technologies to monitor care provision and outcomes. The sixth principle, which was enhanced access, touches really all of these areas. It's enhanced access and continuity of care from a care team. It's care when and how the patient needs it, and it's access to care that is coordinated throughout the healthcare system. Unfortunately, the seventh principle is more about a broader system change than about practice change. It's one that practices can affect primarily through advocacy and participation in patient-centered medical home initiatives. The NCQA just recently released its newest standards, PCMH 2011, which contain the guidance and requirements for practices seeking PCMH recognition. In the new version, there are 6 standards, each with detailed elements and factors a practice has to implement and prove they've met. These standards include enhanced access and continuity. Again, the focus is on access to culturally and linguistically appropriate care and on continuity centered around team-based care. Identify and manage patient populations. This standard is asking practices to identify subgroups or registries of patients based on particular risk factors, utilization patterns, or disease burden. Plan, manage care. This standard focuses on care management, particularly for subgroups identified as being at greater risk. Provide self-care support, community resources. This standard encourages practices to involve patients in clinical decisions and to ensure that patients' needs are supported and met. Track, coordinate care. This standard works to address the fragmentation we've discussed earlier by pushing practices to track tests, referrals, and interactions with other parts of the healthcare system more proactively. Measure, improve performance. Again, encourages practices to use data to improve care quality. The data focus is on clinical outcomes, for instance, improvements in diabetes management, and administrative measures such as improving continuity and access. So why is the program actively pursuing patient-centered medical home recognition, and why now? First, like Heidi mentioned, patient-centered medical home recognition is becoming the new gold standard. It's an emerging benchmark for high-quality organizations. Particularly for healthcare for the homeless programs, it's important to stay on the forefront of how mainstream medicine is changing and to resist further marginalization of our programs. We are serving a vulnerable and marginalized population and do well to make sure that our services don't magnify that. By participating in these mainstream changes and staying at the forefront of healthcare practice, we position ourselves to keep that mainstream responsive to and responsible for our patients. Secondly, we're undertaking this transformation for our practice for some of the very same reasons that the country is moving towards PCMH. High costs with subpar quality indicators. In demonstration projects, the PCMH model has been shown to reduce the overall cost of care and to improve quality, access, and patient satisfaction. The changes required and the outcomes anticipated here are directly aligned with our current strategic direction, and the structure and focus on improving access and quality, both in terms of clinical outcomes and patient satisfaction, support and enforce our ongoing efforts. The way we see it, these are changes we should be making anyway to continue to improve our practice. Centering care around patients. The PCMH model reinforces our patient-centered approach to care and pushes us to look at our care model through the lens of patient-centeredness in a new way, to become more cognizant of how we fall short and to give us a platform to drive improvement. This model emphasizes the importance of involving patients in care decision-making, again, particularly when working with patients who've been disempowered and whose voice is often ignored. Staff satisfaction. It's our sincere hope that though any changes in practice are initially difficult and often quite painful, these changes in practice will eventually reduce redundancies and rework, improve efficiencies, and allow each team member to practice at the top of her or his skill set, thus improving long-term staff satisfaction. There's a current state initiative. Massachusetts is currently undertaking a major PCMH initiative with the goal of having all primary care practices in the state be PCMH recognized by 2015. Our participation is especially important now so that we can be a part of the state's design and interpretation, and so that we can participate in formative discussions and work to argue for accommodations for practices such as ours, which serve special populations. It provides us with a forum to educate stakeholders about our work and our patients and the importance of our model. And finally, there's hope for eventual reimbursement restructure and recognition of the work of patient-centered medical home through enhanced payment methods. Particularly, there's plans for incentives for care coordination and quality improvements rather than the existing model of fee-for-service. I'll talk in a minute about how this particular structure may not immediately work well for programs like ours. In summary, undertaking these enormous process of seeking PCMH recognition will allow us to experiment and transform our delivery model creatively with continuity, quality, cost, and utilization as clear dimensions that need simultaneous consideration. So what are we hoping for? Sometimes it feels like we're asking for the moon, but there are some real measurable outcomes that we hope to achieve through this process. First and foremost, we expect that undertaking this change will result in improved clinical processes, so that BHCHP in particular will have high-functioning teams that provide high-quality care to well-defined panels of patients. By remaining on the cutting edge of healthcare, we hope to benefit from quality improvements and be poised for those enhanced payments should they materialize. Secondly, we intend to achieve Level 3 recognition, which is the highest level of PCMH recognition available from NCQA. So what are the challenges that we foresee? This project is likely to be a money loser, at least for the foreseeable future. The transformation itself requires a substantial investment in administrative and leadership time, in information technology, and in clinical staff time to test and adapt changes to their practice. Once in operation, a PCMH model can be very staff and resource intensive in order to provide good care management and to manage not just face-to-face patient interactions, but also manage panels and do such activities as monitoring clinical outcomes, doing pre-work prior to each visit, analyzing team practice to trim inefficiencies. So we have a few proposed solutions for how we'll overcome this hurdle. First is to seek funding support for early investments in the project team as much as possible. Private foundations in particular may be interested in supporting and investing in this transformative work. Secondly, the transformation of the clinical practice will need to include gains in efficiency, which will mean more visits can be delivered, which in turn can mean an increased billing revenue. And finally, we're starting with a focus on one central site where we will test and implement our changes. These efforts can and likely will be translated to our other areas of our program, particularly for those patients who are most complex and most in need of this enhanced system of care. However, we'll work to mitigate loss by minimizing the rollout of the changes throughout our organization until we can do so sustainably. All in all, I think it's important that the organization recognizes that this project is an investment, and whether or not the financial investments are paid back, it will result in important improvements in the care provided. Care continuity is another potential hurdle for us. Perhaps like many Healthcare for the Homeless programs, Boston Healthcare for the Homeless program's model of care is in many ways necessarily decentralized. We are built on an outreach model and care for patients at nearly 80 different locations. We staff these sites in a way that intends to have familiar faces providing care at multiple locations, improving access and engagement for patients whose lives are inherently decentralized as well. Unfortunately, the model can and has caused significant discontinuity, particularly because it means that our providers are very part-time at any one site. The main solution that we are focusing on is teams. Rather than shake up or abandon the outreach model that is at our core, we've chosen to focus on creating true teams where a consistent group of caregivers across disciplines, that means MDs, NPs, PAs, nurses, case managers, medical assistants, work together and jointly manage a panel of patients. That way, a patient has access to care that is continuous, provided by a team of people who are familiar with that patient's health history and course of treatment. A chronic and preventive care focus. As we all know, among homeless people, preventive care often yields to the immediacy of life in shelters and on the streets. We talked about before that illnesses and injuries often escalate and go from minor treatable symptoms to major illnesses and healthcare emergencies. Our patients, and frankly our providers, struggle to focus on preventive measures and chronic disease management when presented with so many acute issues in such great crisis. And yet there are quality gates for many patient-centered medical home initiatives. There's an expectation and standards that require participating primary care practices to achieve a certain level of quality outcomes. And those outcomes are benchmarked in a much more stable and often healthier population than the population we serve. The solutions we have are pretty simple. Investing in time and staffing required to transform our practice so that chronic care and preventive care are a greater focus of every visit, even those that start off focused on an acute issue. The adage, do today's work today, comes into play here, particularly with homeless patients, putting off the routine and less urgent issue until the next visit in order to focus solely on the acute issue at hand too often means that the patient never receives treatment for the non-acute. This concept is easier to envision and easier to promise to tackle when you have a team with shared ownership of the patient, so that no one person or provider is responsible for remembering, providing, or monitoring all healthcare services. Tracking and follow-up. PCMH emphasizes tracking and follow-up for referrals and tests, but as we all know, homeless patients are often transient and follow-up can be incredibly challenging. The best approach we see to this issue is to maximize our use of health information technology whenever possible. We're fortunate enough to have a state-of-the-art medical record, and we'll be working to ensure that we use it to its fullest capacity. We'll also need to continue our focus and continue to build our collaborative relationships, both with hospitals and other healthcare providers and with the homeless service system, so that we can share information effectively and that we can track patients more quickly. The final hurdle that I'd like to talk about a little today is the focus on savings. We talked a little bit about the hope for changes in reimbursement structure. And while many payer systems are buying into and supporting patient-centered medical home initiatives, there's a focus on savings to the healthcare system. And as healthcare for the homeless programs, we know that our patients tend to be incredibly costly and are often some of the highest utilizers of expensive services, such as emergency rooms. The keys, as we see them, are first to improve our model so that the care we provide is more effective and more efficient. If we're managing our patients better, perhaps their use of and need for other services, particularly those that are emergent, will decrease. Secondly, we need to build our case for why healthcare for the homeless programs are a necessary part of the healthcare system and are already money savers. Though our patients are some of the most expensive, they would be that much more expensive and in need of emergent care if we weren't available to provide their primary care on a day-to-day basis. And finally, for your own sanity and in the interest of having comparisons that are meaningful and valuable, make sure that you're comparing yourself to practices serving similarly complex populations, and also compare yourself to yourself. We're looking for savings and improvements based on our own baseline, not just based on externally set standards. On that note, I'd like to turn the mic back over to Melissa so that we can have a little bit of time to talk through these issues and to answer some questions. Melissa?
Thank you, Joslyn. We did receive one question from Emily, and Emily asks, to be a patient-centered medical home, do you need to provide both primary and mental health care in one location?
Wow, that's a good question. As far as I know, the requirement isn't that you are the sole provider of both primary care and behavioral health care, but that your team is in fact accounting for the needs for both. And if you are solely providing primary care, that you are coordinating the behavioral health care component with your team.
Thank you, Joslyn. Another question from Julie is more about the time frame involved in becoming a patient-centered medical home. How long does it take?
Thanks, Julie. We are at the early stages of this project. As Heidi mentioned, we started this in the fall of 2010 and are still getting our sea legs. But we've given ourselves a full 18 months with the understanding that it'll take approximately 9 months to actually put together the application. The challenge and the reason this takes so long is that first you have to transform your practice and work through each of the standards and earn points as you go. But you also have to then be able to demonstrate that you're meeting each standard, and that demonstration generally includes that you've had that transformative practice in place for a minimum of 3 months. So there's a lot of time to try to build and change your practice, and then there's a lot of time to try to collect data, to try to run reports, to show evidence of that change, and then you put together your entire package to submit to NCQA.
Thank you, Joslyn. We have a question now from Kathy. Kathy asks, how do you see housing and other support services fitting into patient-centered medical home model?
I think, again, the same way that we talked about behavioral health services, particularly with our patients, the importance is the care coordination. So whether or not you are the primary provider of those kinds of support services or social services, the importance is that you're taking those into account, that you are coordinating that care, and that you're working with the providers of that care and with the patient to ensure that all those needs are being met. As we all know, the social support services play a key role in people's ability to adhere to medical treatments and, in fact, in their medical outcomes. So it's important part of patient-centered medical home that the team monitors those issues and coordinates those services, whether or not they are the sole providers of those services. I hope that answers your question.
Thank you, Joslyn. We now have a question from Diana, and she is interested in knowing if patients can have 2 medical homes. For example, her model involves helping patients connect with other healthcare systems, such as the VA, but they are also welcome to return, I guess, to her center if they're not comfortable with the services they receive at the VA. So is it possible to have 2 medical homes?
Our understanding is yes, absolutely. I think particularly with programs like ours where we're both working to coordinate care with other providers, but also often working to coordinate care among our own sites, there's an understanding that what we're transforming is our practice and that we are available to our patients. But if our patients also have a relationship with or interact with other systems, that's a completely legitimate way for them to use the system. So for instance, in our more than 80 sites, we're focusing on one particular location, and we're calling that the patient-centered medical home, the reality is that many, if not most of our patients use multiple sites, and so this would not preclude them from their engagement in our other sites and in other care models, but would ensure that while their care is here, that they are receiving this kind of heightened model, and that in fact part of that is then coordinating the care when they're receiving it elsewhere.
Thank you, Joslyn. A question from Diane. She asks, why is this model, patient-centered medical home, better than the simple primary care model that we have now?
Oh my. Well, you're speaking to a Kool-Aid drinker. So I'm a believer in this model, at least as I see it so far. I think the importance is that it feels to me a little more complete than the way the simplicity of the existing primary care model. I think for us the strictures and the structure that come with it really help us to take our care to a new level, where we've been providing primary care for 25 years, but we see that this model pushes us in a new way and gives us some guidance in ways that we could still improve our care. And I think it's the comprehensiveness and the structure of that model that we see as the benefit that makes it kind of better for us over and above the simple existing primary care model.
Thank you, Joslyn. I have a question here from Troy. Do you have to customize health information technology to recognize a team as the provider, as some systems only recognize one individual provider?
That's a great question, and it's something that we are currently working through and struggling with. I think, it depends on what your practice model is. For ours, as I said, because we are so decentralized and have our staff all over the place, we have fairly large teams. Teams can consist of multiple MDs and PAs, as well as then the nurses, the case managers, etc. And so we do want to customize our EMR in particular to annotate that there's a team presence, and so that there's an understanding of which team is responsible. It is in some sense as simple as taking particular providers' panels and combining them, and then adding a new field that also says, okay, so if the provider is Dr. Smith, then the team is Team Orange. But we are working through that right now, because it will then help us to have panel reports, whether those are panel utilization, looking at the panel membership, or obviously the panel clinical outcomes, that we'll be able to have better panel reports if we have the team annotated in the health information technology systems, rather than trying to go through by hand and try to combine panels.
Thank you, Joslyn. A question now from Bob. How will you know what services your patients are getting from other places, such as hospitals and emergency rooms?
We're still working through what that's going to look like on a day-to-day basis, particularly trying to understand how the clinical teams will get the information, and are working with partnerships with our electronic medical record and with the local hospitals in particular to try to speed up the pace of communication so that we know immediately what services our patients are getting. In the longer term, the benefit of participating in the Massachusetts initiative is that there will be what they're calling an all-payer claims database, which will actually include data on service utilization and some clinical outcomes based on the insurance data, so that our patients' interactions with any systems, all of that data will be in one place, and that data will be shared with the practices who are participating. Our hope is by using that data, by having access to that data, we'll have a better understanding of our patients' interaction with other parts of the system, what those costs are, what those outcomes might be. So there's another real benefit for us in participating in this current state initiative, in that Massachusetts is trying to centralize some of that information.
Thank you, Joslyn. We have another question from Emily, who asks, will you have to be a patient-centered medical home in order to participate within accountable care organizations in the future? I think a safe answer is yes. You will have to acquire that status, if not in terms of like the official recognition, at least in terms of the care you deliver. That model of care needs to be in place. We have come to the end of the Q&A section of our presentation, and I would like to turn the mic back over to our MC, Ms. Heidi Nelson. Heidi?
Thanks, Melissa, and thank you so much, Joslyn. That was a fantastic presentation. Thank you so much. Let me call the attention of our audience to resources and activities of the National Healthcare for the Homeless Council. The National Council is a membership organization having strong, mutually supportive relationships with and among our members. You can join us as an individual, or your agency can become an organizational member. When you join, you can subscribe to the HCH Mobilizer, and this is a handy way to stay alert and act in support of healthcare for homeless people. At this point, I'll turn it back to Melissa to close us out.
Thank you, Joslyn Allen Strupp, for that wonderful presentation. Thank you, Ms. Heidi Nelson, for serving as our MC. Thank you all again for participating in this webinar, Patient-Centered Medical Home, Introduction to a Concept. This meeting has now come to a close.